Our final speaker is Dr. Jan Vermorken, and Dr. Vermorken is from the University Hospital, Antwerp in Belgium, and he will speak on biologics and chemotherapy in the recurrent and metastatic setting. Jan?
So, Mr. Chairman, thank you very much, and I'd like to thank the organizers for inviting me here. Well, after everything that you have heard, let me first say that I have some disclosures to make here, but I don't think it will have a lot of interference with what I'm going to tell you. Now, the factors that need to be considered in choosing treatment options in recurrent metastatic disease are basically the type of relapse and the time interval.
Sorry. Could we cut the chatter, please, if that's okay? Thanks.
And the time interval between the primary treatment and the time that the relapse is occurring. Then the type of treatment that the patient received the first time in a curative setting. And of course, as it has been mentioned, performance status, comorbidities, patient preference, and logistics. It makes a difference where you are being treated. It makes a difference whether you're being treated in a cancer hospital or a department at a university hospital where there are possibilities to participate in experimental treatments. Now, to go a little bit further on that, the type of relapse, of course, we can divide that in local and or regional, metastatic only, or both. And then concerning the primary treatment, nowadays much more patients have combined modality treatment the first time when they have advanced disease. And then you can think of surgery followed by any form of local treatment, concurrent chemoradiotherapy or bioradiotherapy or induction chemotherapy followed by any form of local treatment. And again, as it was mentioned, the interval, the duration of interval is important. When you have a short interval after concurrent chemoradiotherapy in general, the outcome is poor. Now, it was mentioned in previous presentation that I would show you this slide. This is from the Fakhri paper that came out just recently. And it shows you very clearly that whatever type of relapse, the patients who have P16 positive tumors are doing better. So you see in A, you see the patients that have a local regional recurrence. In B, the patients who have distant recurrence. In C, whether they had salvage surgery, and in D, whether they did not have salvage surgery. So what you can see is that the patients who develop a distant relapse do worse than the ones that have a local regional relapse. And I think it's interesting to see that in all those cohorts of relapsing patients, the P16 positive patients are doing better. Now, concerning the treatment options, it has been mentioned before, and I would like to stress that at all times, we should try to see whether the patient can be resected for his tumor. The best chance for cure in that situation is the early stage recurrent tumors and the recurrent cancers from the larynx. Reirradiation has been extensively discussed by Brian, and I will talk a little bit about the systemic treatment. Now, the medical treatments that we're talking about, many patients unfortunately are being treated for palliation. Some of them will receive only best supportive care, the others best supportive care with cytotoxic agents, single agent or combinations, or targeted therapies, again, single agent or combinations, and immunotherapy. And then there are some specific situations where you can think about the use of hyperthermia, for instance, or electrochemotherapy, but I'm not going to talk about that. I want to stress first that when we talk about squamous cell carcinoma of the head and neck, this is a chemosensitive disease. And the fact that I say this is because there are so many drugs that induce more than 50% response, and they are from different categories, as you see here. So that's one thing. The second thing is that if you look for randomized trials with single agents, there is no trial ever reported that showed that one single agent is superior over the other. And therefore, I think the toxicity issue is an important one. Methotrexate, especially in European countries, is still being used for palliation, an easy drug that is already available for since World War II, and we still use it for patients that are not fit enough. Now, for randomized studies, I put in yellow the platinum 5-FU regimen, which is the regimen that was developed by Al-Sarraf, as you know, and that was used for induction chemotherapy, but also with a shorter infusion time of 5-FU for recurrent metastatic disease. Now, in all the randomized trials where it was used and compared to single agent, you see that indeed there is more response. So for a patient that is symptomatic, it is logic if the patient is in a reasonable good condition to use it, but it doesn't have an impact on survival. There is one paper that I would like to mention separately on this slide. That is the Gibson trial, and the Gibson trial was a trial where platinum 5-FU was compared to a taxane with platinum. And the outcome of that trial was there was no difference, but there was a difference in toxicity. In particular, for the patients that have been treated with radiation before, there is less stomatitis when you use the taxane-based regimen. Now, that study was ECOG 1395. And you see here, and I think that this is one of the most interesting papers that I think is in recurrent metastatic disease, is from Ethan Argyris. They did an analysis on 2 of ECOG trials. The 1393 is 2 doses of taxanes, and E1395 I just mentioned to you. The message from this paper is that, first of all, also with chemotherapy, some patients stay alive until 5 years. It's a small percentage, but it is a fact of life. And the factors that have a prediction for outcome for overall survival is severe weight loss, a poor performance status, well-differentiated or moderately differentiated disease, and a tumor that originates in the oral cavity or hypopharynx, and a history of radiation. Now, if these factors are, of course, in unbalance in trials, you can imagine that these trials will be very difficult to interpret. What was found also in ECOG 1395, and that was presented a year ago at ASCO, is that they found with cytotoxic chemotherapy that the patients with HPV positive status or P16 positive status had a better survival. So this is in line with what I mentioned already in the slide from the Fakhri paper. Second, the second-line chemotherapy, and this is important to realize because there are several trials ongoing in second-line recurrent metastatic disease. And I put here together what you may expect from median progression-free survival. You see, in those studies where it is reasonably good to analyze, it ranges from 1.5 to 2.1 months. So it's really quite poor. And the survival is somewhere between 4 and 6 months. Now, how is it with the new targeted agents? You see here the different targets of next generation therapies, and in particular the one in yellow, the growth factors and growth factor receptors. And then in particular, the HER family is important here because cetuximab, as one representative of that, is approved for treatment in head and neck cancer. There are 3 trials completed in first-line recurrent metastatic disease. There is a paper from ECOG, a rather small paper showing that there was benefit of adding cetuximab to platinum in terms of response rate. We have the EXTREME trial that confirms that, but also showed as the only trial a survival benefit, and that has changed practice. And then there is a third trial, the SPECTRUM trial, where panitumumab was combined with platinum 5-FU versus platinum 5-FU. There was also clearly an indication of efficacy, but it did not reach statistical significance with respect to overall survival. Can I have the next slide, please? What is, I think, interesting from the EXTREME trial is that when we looked at P16 positive and P16 negative patients, we did that also for HPV itself, you see that it is prognostic. And in this study, it is not predictive. That means in both cohorts, you see the beneficial effect of adding cetuximab to the chemotherapy. Now that is of course interesting because in the other trial, the Spectrum trial that I just mentioned to you, that effect was not seen. It was also prognostic, but it was also predictive in a sense that it was only effective in the P16 negative patients. So there is not a unanimous feeling about whether the HPV state is predictive when you use biological agents. What I think is very discouraging is that when we look at the long-term follow-up of the Extreme trial, and this was reported this year at ASCO, you see that it's not really a major improvement. Unfortunately, only 8 out of the 44 patients are alive. So you talk about the Extreme arm of about 2.6% 5-year survival. So it's very, very low. So there is a gain in median survival, there is not a gain in long-term survival. Again, when we use anti-EGFR medication in second line, and I put in yellow the data where I'm pretty certain that these figures are realistic, you see that when cetuximab is used in second line in platinum refractory patients, you may expect a median progression-free survival somewhere from 2.2 to 2.8 months. In the other studies, there are some where it goes up a little bit higher, but this is overall what you may expect. And the survival is a little bit better than what we have seen in second-line cytotoxic chemotherapy. So I think the message is, if you're doing randomized trials in second line, take into account what you may expect in your control arm, because we make many mistakes in calculations in our statistical paragraph, what we may expect from our trials. Unfortunately, completed randomized trial in second line, this is what has been published so far, the IMAX trial comparing gefitinib with methotrexate, the ECOG trial adding gefitinib to docetaxel, and the Salute trial looking for salutumumab versus best supportive care. Unfortunately, no significant difference. Is borderline survival improvement in the Salute trial, but it didn't reach significance. And then, of course, other novel targeted agents are of interest, but I'm not going in details about this because there is a lot of data, and you have heard also during the meeting here some stimulating data, but there is no phase 3 data available, which may give you a lead what to do. I cannot end this talk without at least mention to you that we were all really extremely stimulated at ASCO, where immune therapy again seemed to play a role also for the treatment of head and neck cancer. And we're talking here about the deblocking effect of antibodies between the interaction of PD-1 and the ligands. And I think that that is, I think, a very interesting observation. In the mouse models that has led to tumor rejection, but also in the clinic, beneficial effects have been seen. And one of these drugs, pembrolizumab, was reported by Tanguy Seward at ASCO, and very interestingly, he showed that both in HPV positive and in HPV negative cohorts, there is about a 20% response. And clearly, when you look in those tumors that have a high expression of PD-L1, the response rate goes up to even 40%. Now, the interesting aspect is that these responses were of long duration. And so that is something of interest because it reminds you what we have seen with this kind of approaches also in melanoma patients. So I really hope that this will be of benefit to our patients. He showed one of these cases, a dramatic case with a local regional recurrence, as you see here, but also with distant metastasis in the lung of a patient that was treated. Initially had a flare-up, the same thing that you have seen with ipilimumab in melanomas. You see this here also in this case on the right side, and then ultimately improvement with a near complete response after 6 months. So I think the conclusion of what I have shown you is that I think, first of all, recurrent metastatic disease is a heterogeneous population with respect to extent of disease, prior therapy, and time interval to relapse. But also in terms of biology. The extreme regimen is the new standard in first-line treatment in good clinical condition. It's recommended in both in the US and in Europe. HPV status has impact on survival in recurrent metastatic disease, but HPV status might have a different predictive value for effects of different biological agents, and therefore it needs to be studied further. Reactivation of immune surveillance by blocking PD-1 interaction with its ligands is a promising approach, perhaps. Overall, I must say that the outcome of the patients is still poor and that trial participation is highly recommended. Thank you very much for your attention.